All right, here we have an interesting case on hand. A patient presenting with neurological symptoms that we'll dig into based on these MRI images of the cervical and upper thoracic spine. Starting from the findings, immediately something stands out. The spinal cord is visibly abnormal from the level of C3 to T4. What grabs my attention first is that the cord is expanded at these levels. Looking more closely, there's an intramedullary lesion present, showing high signal intensity on T2 weighted images, which is quite homogeneous. When I compare that with the T1 weighted images, the lesion is mostly isointense without any significant contrast enhancement. This absence of enhancement is crucial and will help narrow down our differential diagnoses as we move forward. Now, what's notable here is that there's no cerebrospinal fluid visible anteriorly or posteriorly around the spinal cord at these levels, which hints at how tightly packed the cord is within the vertebral canal. I'm also seeing some posterior disc and osteophyte bulges in the mid-cervical spine, although they don't seem to be causing compression at the affected levels. So the disc changes are a secondary finding, not directly related to the primary pathology we're dealing with here. Given the level of involvement, my initial thought process takes me through several potential diagnoses. If this was a more gradual presentation of symptoms, I'd be leaning toward an intramedullary spinal cord tumor. And what would we typically think of in that case? Ependymoma, astrocytoma, or perhaps a hemangioblastoma. However, the lack of enhancement makes these tumors less likely, especially hemangioblastoma. But let's pivot and consider the possibility of a more acute presentation. Here's where my focus really sharpens on spinal cord infarction. The high signal on T2 and the lack of enhancement are strongly suggestive of this. Another key point is the absence of trauma history, so while a hematoma could be another consideration, it becomes less likely here. When I piece together these findings, the sudden onset of neurological deficits, the appearance on MRI without significant contrast enhancement, I'm leaning towards a diagnosis of an acute spinal cord infarction. This also fits with the restricted diffusion seen on diffusion-weighted imaging, which was indeed evident when I reviewed the rest of the images from the scan. Of course, a question that would naturally arise is, what might have caused this infarction? Well, spinal cord infarction can occur spontaneously, but it's also well documented following certain procedures like open aortic aneurysm repair or bronchial artery embolization. And let's not forget about the artery of Adam-Kiewicz. If that's inadvertently occluded during one of these procedures, we could end up with an infarction in the cord. So, my plan moving forward would be to discuss this case with the referring clinician, reviewing the remaining diffusion-weighted images in detail. We need to confirm the extent of the infarction and potentially assess the clinical history for any procedural links. Before I wrap up, let me emphasize that this underscores the importance of rapid and accurate imaging in cases of sudden neurological decline. MRI, with its ability to capture the cord expansion and intramedullary high signal, remains our best tool here, supplemented by diffusion-weighted imaging to really clinch the diagnosis. All right, that's it for this case. If you found this breakdown helpful, make sure to subscribe to my channel, Radiology Made Easy, for more insights like this. Thanks for listening.